CPT guidelines. Fine needle aspiration, FNA biopsy. A fine needle aspiration, FNA biopsy is performed when material is aspirated with a fine needle, and the cells are examined. Cytologically, a core needle biopsy is typically performed with a larger bore needle to obtain a core sample of tissue for histopathologic evaluation. FNA biopsy procedures are performed with or without imaging guidance. Imaging guidance codes are reported once per lesion sampled in a single session. More than one FNA biopsy is performed on a separate lesion at the same session, same day, same imaging modality. Use the appropriate imaging modality. Add-on code for the second and subsequent lesion. When more than one FNA biopsy is performed on a separate lesion, same session, same day, using different imaging modalities, report the corresponding primary code with modifier 59 for each additional imaging modality and corresponding add-on code for subsequent lesions sampled. This instruction applies regardless of whether the lesion are ipsilateral or contralateral to each other, and or whether they are in the same or different organ structures. When FNA biopsy and core needle biopsy are both performed on the same lesion, same session, same day using the same imaging guidance, do not separately report the imaging guidance for the core needle biopsy. When FNA biopsy is performed on one lesion and a core needle biopsy is performed on a separate lesion, same session, same day using the same type of imaging guidance, both the core needle biopsy and the imaging guidance for the core needle biopsy may be reported separately with modifier 59. Modifier 59 distinct procedural service. When an FNA biopsy is performed on one lesion and a core needle biopsy is performed on a separate lesion, same session, same day using different types of imaging guidance, the core needle biopsy and the imaging guidance for the core needle biopsy may be reported with modifier 59. Modifier 59 distinct procedure service. Integumentary system. Skin, subcutaneous, and accessory structures. Introduction and removal. Soft tissue marker placement with imaging guidance is reported with code 10035 and code 10036. If a more specific site descriptor than soft tissue is applicable, for example, breast, use the site-specific codes for marketplace at that site. Report code 10035 and code 10036 only once per target, regardless of how many markers, for example, clips, wires, pellets, radioactive seeds, are used to mark that target. Debridement, wound debridements, 11042 through 11047, are reported by depth of tissue that is removed and by surface area of the wound. These services may be reported for injuries, infections, wounds and chronic ulcers. When performing debridement of a single wound, report depth using the deepest level of tissue removed. In multiple wounds, sum the surface area of those wounds that are the same depth. Do not combine sums from different depths. For example, when bone is debris from 4 cm square heel ulcer and from a 10 cm square ischial ulcer, report the work with a single code, 11042, or 11044 as appropriate. Biopsy. The use of a biopsy procedure code, for example, 11102 through 11107 indicates that the procedure to obtain tissue solely for diagnostic histopathologic examination was performed independently, or was unrelated or distinct from other procedure services provided at that time. Biopsies performed on different lesions or different sites on the same date of service may be reported separately, as they are not considered components of other procedures. During their surgical procedures in the integumentary system, such as incisions, destruction, or shave removals, the removed tissue is often submitted for pathologic examination. The obtaining of tissues for pathology during the course of these procedures is a routine component of such procedures. This obtaining of tissues is not considered a separate biopsy procedure and is not separately reported. Partial thickness biopsies are those that sample a portion of the thickness of the skin or mucous membrane and do not penetrate below the dermis or lamina propria. Full thickness biopsies penetrate into deep tissue into the dermis or lamina propria, into the subcutaneous or submucosal space. Sampling of stratum corneum only, by any modality, for example, skin scraping, tape stripping, does not constitute a skin biopsy procedure and is not separately reportable. An appropriate technique is selected based on optimal tissues, sampling considerations for the type of neoplastic, inflammatory, or other lesion requiring a tissue diagnosis. Biopsy of the skin is reported under 3 distinct techniques. Tangential biopsies, for example, shave, scoop, saucerize. Curette is performed with sharp blade, such as a flexible biopsy blade, obliquely oriented scalpel or curette to remove a sample of epidermal tissue with or without portions of underlying epidermis. The intent of a tangential biopsy, 11102 AN, add-on code, 11103, is to obtain a tissue sample from a lesion for the purpose of diagnostic pathological examination. Biopsy lesions of a tangential technique, 11102 AN, add-on code, 11103, is not considered an excision. Tangential biopsy technique may be represented by a superficial sample and does not involve the full thickness of the dermis, which could result in portions of the lesion remaining in deeper levels of the dermis. For therapeutic removal of epidermis or dermis lesions, using shaving technique, C11300 through 11313. An indication for a shave removal. 11300 through 11313 procedure may include a sympathetic lesion that rubs on the waistband or bra, or any other reason why elevated lesion is being completely removed by shaving technique, suggesting a therapeutic intent. It is the responsibility of the physician of qualified healthcare professional performing the procedure to clearly indicate the purpose of the procedure. Punch biopsy requires a punch tool to remove a full-thickness cylindrical sample of skin. The intent of a punch biopsy, 11104 AN, add-on code, 11105, is to obtain a cylindrical tissue sample of cutaneous lesion for the purpose of diagnostic pathological examination. Simple closure of the defect is included in the service. Manipulation of the biopsy defect is to improve. Wound approximation is included in simple closure. Incidental biopsy requires the use of a sharp blade, not a punch tool, to remove a full-thickness sample of tissue via a vertical incision or wedge, penetrating deep to the dermis, into the subcutaneous space. The intent of the incisional biopsy, 11106 AN, add-on code, 11107, is to obtain a full-thickness tissue sample of a skin lesion for the purpose of diagnostic pathological examination. This type of biopsy may sample subcutaneous fat, such as those performed for the evaluation of panniculitis. Although closure is usually performed on incisional biopsies, simple closure is not separately reported. When multiple biopsy techniques are performed during the same encounter, only one primary lesion biopsy code, 11102, 11104, 11106, is reported. Additional biopsy code should be selected based on the following convention. If multiple biopsies of the same type of performed, the primary code for that biopsy should be used along with the corresponding add-on code, S. If an incisional biopsy is performed, report 11106 in combination with a tangential, add-on code, 11103, punch, add-on code, 11105, or incisional biopsy, add-on code, 11107. For additional biopsy procedures, if a punch biopsy is performed, report 11104 in a combination with tangential, add-on code, 11103, or punch, add-on code, 11105. For additional procedures, if multiple tangential biopsies are performed, report range biopsy, 11102, in combination with, add-on code, 11103 for additional tangential biopsy procedures. When two or more biopsies of the same technique, that is, tangential, punch, or incisional are performed on separate additional lesions, use the appropriate add-on code, 11103, 11105, 11107, to specify an additional biopsy. When two or three different biopsy techniques, that is, tangential, punch, incisional are performed to sample separate additional lesions, select the appropriate biopsy code, 11102, 11104, 11106, plus an additional add-on code, 11103, add-on code, 11105, add-on code, 11107. For additional biopsies performed, removal of skin tags, removal by scissoring or any sharp method, ligature strangulation, electrosurgical destruction or combination of treatment modalities, including chemical destruction or electrocauterization of wound, with or without local anesthesia, shaving of epidermal or dermal lesions. Shaving is the sharp removal by trails versus incision or horizontal slicing to remove epidermal and endermal lesions without a full thickness. Dermal excision. This includes local anesthesia, chemical or electrical catheterization of the wound. The wound does not require suture closure. Excision benign lesions. Excision, including simple closure, of benign lesions of skin. For example, neoplasm, cicatrical, fibrous, inflammatory, congenital, cystic lesions. Includes local anesthesia. See appropriate size and area below. For shave removal, C11300 at the following, and for electrosurgical and other methods C17000 at the following. Excision is defined as full thickness, through the dermis removal of lesion, including margins, and includes simple, non-layered, closure when performed. Report separately, each benign lesion, excised. Code selection is determined by measuring the greatest clinical diameter of the apparent lesion plus that margin required for complete excision. Lesion diameter plus the most narrow margins required equals the excision diameter. The margin referred to the most narrow margin required to adequately excise the lesion. Based on individual judgment, the measurement of all lesion plus margin is made prior to excision. The excised diameter is the same whether the surgical defect is repaired in a linear fashion, or reconstructed. For example, with a skin graft, the closure of defects created by incision, excision or trauma may require intermediate or complex closure. Repair by intermediate or complex closure should be reported separately. For excision of benign lesions, requiring more than simple closure, that is, requiring intermediate or complex closure, report 11400 through 11446 in addition to appropriate intermediate, 12031 through 12057, or complex closure, 13100 through 13153. Codes. For reconstructive closure, C15002 through 15261, 15570 through 15770. For excision performed in conjunction with adjacent tissue transfer, report only the adjacent tissue transfer code 14000 through 14302. Excision of lesion 11400 through 11446 is not separately reportable with adjacent tissue transfer. See pages 94 and 95 for the definition of intermediate or complex closure. Excision malignant lesions. Excision, including simple closure, of malignant lesions of skin. For example, basal cell carcinoma, squamous cell carcinoma, melanoma including local anesthesia. See appropriate size and body area below. For destruction of malignant lesion of the skin, see destruction codes 17260 through 17286. Excision is defined as full thickness through the dermis removal of all lesion, including margins. Includes simple, non-layered closure when performed. Report separately each malignant lesion excised. Code selection is determined by measuring the greatest clinical diameter of the apparent lesion plus that margin required for a complete excision. Lesion diameter plus the most narrow margins required equals the excised diameter. The margins referred to the most narrow margin required to adequately excise the lesion. Based on the physician's judgment, the measurement of all lesion plus margin is made prior to excision. The excised diameter is the same whether the surgical defect is repaired in a linear fashion or reconstructed. For example, with a skin graft, the closure of defects created by incision, excision or trauma may require intermediate or complex closure. Repair by intermediate complex closure should be reported separately. For excision of malignant lesions, requiring more than simple closure, that is, requiring intermediate or complex closure, report 11600 through 11646 in addition to appropriate intermediate, 12031 through 12057, or complex closure, 13100 through 13153. Codes. For reconstructive closure, see 15002 through 15261, 15570 through 15770. For excision performed in conjunction with adjacent tissue transfer, only adjacent tissue transfer code 14000 through 14302. Excision of lesion 11600 through 11646 is not separately reportable with adjacent tissue transfer. See pages 94 and 95 for the definition of intermediate or complex closure. When frozen section pathology shows the margin of excision were not adequate, additional excision may be necessary for complete tumor removal. Use only one code to report the additional excision and re-excision. Based on final widest excised diameter required for complete tumor removal at the same operative session. To report a re-excision procedure performed to widen margins at a subsequent operative session, see codes 11600 through codes 11646. As appropriate, amend Modifier 58. Modifier 58 stage or related procedure or service by the state provision or other qualified healthcare professional during the postoperative. If the re-excision procedure is performed during the postoperative period of the primary excision procedure, repair, closure. Use the codes in this section to designate wound closure, utilizing sterile, sutures, staples, or tissue adhesives. For example, 2-cyanoacrylates, either singly or in combination with each other, or in combination with adhesive strips. Chemical cauterization, electrocauterization, or wound closure utilizing adhesive strips as the sole repair material are included in the appropriate evaluation and management code. Definitions. The repair of wounds may be classified as simple, intermediate, or complex. Simple repair is used when the wound is superficial, for example, involving primarily epidermis, or dermis or subcutaneous tissue without significant involvement of deeper structures, and requires 1. Layer closure. Hemostasis and local topical anesthesia, when performed, are not reported separately. Intermediate repair includes the repair of wounds that, in addition to the above, require layered closure of one or more of the deep layers of subcutaneous tissue and superficial, non-muscle, fascia, in addition to the skin, epidermal and dermal, closure. It includes limited undermining, defined as a distance less than the maximum width of the defect, measured, perpendicular to the closure line, along at least one entire edge of the defect. Single, layer closure of heavy contaminated wounds that have required extensive cleaning or removal of particular matter also constitutes intermediate repair. Complex repair includes repair of wounds, in addition to the requirements of intermediate repair, require at least one of the following: exposure of bone, cartilage, tendon, or named neurovascular structure, debridement of wound edges, for example, traumatic lacerations or avulsions, extensive undermining, defined as a distance greater than or equal to maximum width of the defect, measured perpendicular to the closure line, along at least one entire edge of the defect, of involvement of free margins of helical rim, vermilion border, or nostril rim, placement of retention sutures. Necessary preparation includes creation of limited defect for repair or the debris of complicated lacerations or avulsions. Complex repair does not include excision of benign, 11400 through 11446 or malignant, 11600 through 1464 lesions. Excisional preparation of a wound bed, 15002 through 15005, or debridement of an open fracture or open dislocation. Instructions for listing services at time of wound repair. 1. The repaired wound, should be measured recorded in centimeters, whether curved, angular, or stellate. 2. When multiple wounds are repaired, add together the length of those in the same classification, see above, and from all anatomical sites that are grouped together in the same code descriptor. For example, add together the length of intermediate repairs to the trunk and extremities. Do not add length of repairs from different groupings of anatomical sites, e.g., face and extremities. Also, do not add together list of different classifications, e.g., intermediate and complex repairs. When more than one classification of wounds is repaired, list the more complicated as the primary procedure and complicated as secondary procedure, using Modifier 59. Modifier 59 Distinct Procedural Service 3. Decontamination and/or debridement. Debridement considered a separate procedure only when gross contamination requires prolonged cleaning, when appreciable amounts of devitalized or contaminated tissue are removed, when debridement is carried out separately without immediate primary closure. 4. Involvement of nerves, blood vessels, and tendons. Report under appropriate system, nervous, cardiovascular, musculoskeletal for repair of these structures. The repair of these associated wounds is included in primary procedure unless it qualifies as a complex repair, in which case Modifier 59. Modifier 59 Distinct Procedural Service applies. Simple litigation of vessels in an open wound is considered part of any wound closure. Simple exploration of nerves, blood vessels or tendons exposed in an open wound is considered part of the essential treatment of the wound and is not a separate procedure unless appreciable dissection is required. If the wound requires enlargement, extension of dissection, to determine penetration, debridement, removal of foreign body, s. Litigation regulation of minor subcutaneous, and/or muscular blood vessel, s. Of the subcutaneous tissue, muscle, fascia, and/or muscle, not requiring thoracotomy or laparotomy. Use codes 20100 through 20103, as appropriate. CPT adjacent tissue transfer or rearrangement. For full thickness repair of lip or eyelids, see respective anatomical subsections. Codes 14000 through 14302 are used for excision, including lesion, and/or repair by adjacent tissue transfer or rearrangement. For example, Z-plasty, W-plasty, VY-plasty, rotation flap, random island flap, advancement flap. When applied in repairing lacerations, the procedures listed must be performed by the surgeon to accomplish the repair. They do not apply to direct closure or rearrangement of traumatic wounds, incidentally resulting in these configurations. Undermining alone of adjacent tissues to achieve closure, without additional incisions, does not constitute adjacent tissues transfer. See complex repair codes 13100 through 13160. The excision of benign lesion, 11400 through 11446, or malignant lesion, 11600 through 11646, is not separately reportable with codes 14000 through 14302. Skin graft necessary to close secondary defect is considered an additional procedure. For purposes of code selection, the term defect includes the primary and secondary defect. The primary defect resulting from the excision and the secondary defect resulting from flap designed to perform the reconstruction are measured together to determine the code. Skin replacement surgery. Skin replacement surgery consists of surgical preparation and topical placement of an autograft, including tissue-cultured autograft or skin substitute graft, that is, homograft, allograft, xenograft. The graft is anchored using the individual's choice of fixation. When services are performed in office, routine dressing supplies are not reported separately. The following definition should be applied to those codes that reference 100 centimeters squared or 1% of body area of infants and children when determining the involvement of body size. The measurement of 100 centimeters squared is applicable to adults and children 10 years and older, and percentages of body surface area apply to infants and children younger than 10 years of age. The measurements apply to the size of the recipient area. Procedures involving wrist and/or ankle are reported with codes that include arm or leg in the descriptor. When primary procedure requires skin substitute for skin autograft or definitive skin closure, for example, orbitectomy, radical mastectomy, deep tissue removal, use 15100 through 15278 in conjunction with primary procedure. For biological implant for soft tissue reinforcement, use 15777 in conjunction with primary procedure. The supply of skin substitute grafts should be reported separately in conjunction with 15271 through 15278. Surgical preparation codes 15002 through 15005 for skin replacement surgery describe the initial services related to preparing a clean and viable wound surface for placement of an autograft, flap, skin substitute graft or negative pressure wound therapy. In some cases, closure may be possible using adjacent tissue transfer, 14000 through 14061, or complex repair, 13100 throughout 13153. In all cases, appreciable non-viable tissue is removed to treat a burn, traumatic wound or a necrotizing infection. The clean wound bed may also be created by incisal release of a scar contracture resulting in a service area defect from separation of tissues. The intent is to heal the wound by primary intention, or by the use of negative pressure wound therapy. Patient conditions may require the closure or application of graft. flap, or skin substitute to be delayed, but in all cases, the intent is to include these treatments or negative pressure wound therapy to heal the wound. Do not report 15002 through 15005 for removal of non-viable tissues debris in a chronic wound. For example, venous or diabetic, when the wound is left to heal by secondary intention. See Active Wound Management Codes 97597 and 97598, and debridement codes 11042 through 11047 for this service. For necrotizing soft tissue infections in specific anatomic locations, see 11004 through 11008. Select the appropriate code from 15002 through 15005 based upon location and size of the resultant defect. For multiple wounds, sum the surface area of all wounds from all anatomical sites that are grouped together into the same code descriptor. For example, sum the surface area of all wounds on trunk and arms. Do not sum wounds from different groupings of anatomical sites. For example, face and arms. Use 15002 or 15005, as appropriate, or excision and incisional releases, resulting in the rules up to and including 100 cm² of surface area. Use 15003 or 15005 for each additional 100 cm² or part thereof. For example, surgical preparations of a 20 cm² rule upon the right hand and 15 cm² wound upon the left hand would be reported with a single code, 15004. Surgical preparation of a 75 square centimeter wound on the right thigh and a 75 cm² on the left thigh would be reported with 15002 for the first 100 cm² and 15003 for the second 50 cm². If all four wounds required surgical operation on the same day, use modifier 59 with 15002 and 15004. Autografts. Tissue cultured autografts include the harvest and or application of an autologous skin graft. Repair of donor site requiring skin graft or local flaps is reported separately. Removal of current graft and or simple closure of the wound is included. When performed, do not report 97602. Debridement is considered a separate procedure only when gross contamination requires prolonged cleaning. When appreciable amount of devitalized or contaminated tissue is removed or when the debridement is carried out separately without immediate primary closure. Select the appropriate code from 15040 through 15261 based upon type of autograft and location and size of the defect. The measurements apply to the size of the recipient area for multiple wounds. Sum the surface area of all wounds from all anatomical sites that are grouped together into the same code descriptor. For example, from the surface area of all wounds on the trunk and arms. Do not sum wounds from different groupings of anatomical sites. For example, face and arms. Skin substitute graft include non-autologous human skin, dermal or epidermal, cellular, and acellular grafts. For example, homograft, allograft, non-human skin substitute graft, that is, xenograft, and biological products that form a sheet scaffolding for skin growth. These codes are not to be reported for application of non-graft wound dressings. For example, gel, powder, ointment, foam, liquid, or injected skin substitutes. Application of non-graft wound dressing is not separately reportable. Removal of current graft and or simple cleaning of the wound is included. When performed, do not report 97602. Debridement is considered a separate procedure only when gross contamination requires prolonged cleaning, when appreciable amount of devitalized or contaminated tissue removed, or when debridement is carried out separately without immediate primary closure. Select the appropriate code from 15719 through 15278 based upon location inside of the defect. For multiple wounds, sum the surface area of all wounds from all anatomical sites that are grouped together into the same code descriptor. For example, sum of the surface area of all wounds on trunk and arms. Do not sum wounds from different groupings of anatomical sites. For example, face and arms. The supply of skin substitute graft, S, should be reported separately in conjunction with 15271 through 15278. For biologic implant for soft tissue reinforcement, use 15777 in conjunction with code for primary procedure. Flaps, skin and or deep tissues. The regions listed refer to the recipient area, not the donor site. When flap is being attached in a transfer or final site, the region listed refer to a donor site when a tube is formed for later transfer or when delay of flap occurs prior to transfer. Codes 15733 through 15738 are described by donor site of muscle, myocutaneous, or fasciocutaneous flap. Codes 15570 through 15738 do not include extensive immobilization. For example, large plaster casts and other immobilizing devices are considered additional separate procedures. A repair of a donor site, a skin graft or local flaps is considered an additional separate procedure. Other flaps and grafts. Code 15740 describes a cutaneous flap, transposed onto a nearby, but not immediate adjacent defect, with a pedicle that incorporates an anatomically named axial vessel into its design. The flaps typically transferred through a tunnel underneath the skin and sutured into its new position. The donor is closed directly. Neurovascular pedicle procedures are reported with 15750. This code includes not only skin, but also a functional motor or sensory nerve, S. The flap serves to reinnervate a damaged portion of the body dependent on touched-on movement. For example, Thumb. Repair of donor site requiring skin graft or local flaps should be reported as an additional procedure. For random island flaps, VY subcutaneous flaps, advancement flaps, and other flaps from adjacent areas without clearly defined anatomically named axial vessels, C 14000 through 14302. Code 15769 may be used to report autologous soft tissue grafts, such as fat, dermis, fascia, or other soft tissues, which are harvested from the patient using an excisional technique. The autologous grafts that are already defined in the CPT code set, including skin, bone, nerve, tendon, fasciolata or vessels, should be reported with the specific code for each tissue type. For harvesting, preparation, or injection, of platelet-rich plasma, use 0232T codes 15771 through 15774 may be used to report autologous fat grafting when the adipose cells are harvested via a liposuction technique, prepared with minimal manipulation, and the injected via cannula in multiple small aliquots to the defect. The regions listed referred to the recipient site, not the donor site. Volumes are based on total injected. For multiple sites of injection, sum the total volumes of injected to anatomical sites that are grouped together into the same code descriptor. Do not report 11951 through 11954 in conjunction with 15771 through 15774 for the same and anatomical site.